Okay, 8:01. I'm going to go ahead and begin. So, good morning, everyone, and welcome again to Grand Rounds. And as I always say, I am so appreciative of you spending an hour of time coming to spend time learning about great things in medicine. So I just want to, this is, Matt said I'm going to say a little bit of a downer thing, and his Grand Rounds are going to have to pick everybody up. But today at 7 o'clock is the sunset. It will be the last time the sun sets 7 or after until March. But on another note, it's going to be 80 degrees today, so get out and enjoy the beautiful weather. So we have had, I believe, 2 incredible Grand Rounds to start off our Grand Rounds this year. Or is it 3? And we have another fantastic speaker who's actually one of our new faculty members. So today, Dr. Matthew Churpek, MD, MPH, PhD, is going to be talking to us. He is a visiting professor, but that doesn't mean he's not. It means that when you come here and you're tenured, you have to get your promotion package together. So that's why it says visiting. He's in the Division of Allergy, Pulmonary Critical Care Medicine here in our department. And the title of his talk is Using Big Data to Detect Clinical Deterioration. Sorry about that. So, as you know, I always tell you a little bit about our speaker. And so Dr. Churpek has just done some fantastic things in his career so far. He did his medical degree at Duke University, and during that time he did an MPH at North Carolina, Chapel Hill. He then went to University of Chicago, where he spent the majority of his training time, and he did his internship there at University of Chicago, followed by his residency. He was also a chief resident, then went on to do his Pulmonary Critical Care Fellowship, during which time he did a PhD in epidemiology as well. Interestingly, he is in the inaugural class of faculty and innovators for the Center of Health Service Delivery, Science and Innovation at University of Chicago, getting a PhD in that as well. He then went on and was an assistant professor of medicine at the University of Illinois Chicago in the section of Pulmonary Critical Care Medicine. And we were incredibly lucky to have him join us on faculty just this summer in August, on August 1st. And I will say his wife is also an incredible physician. And I think one of the things I've been able to do as interim chair is been able to bring this incredible couple to join us here at University of Wisconsin. Interestingly, he has a board certification in clinical informatics, which is one of the new certifications available to people. He has over 64 peer-reviewed articles. He has 3 current grants, including his R01 in sepsis, which is the love of what he's doing right now. Just like Dr. Bartels last week, he has mentored people from undergraduate to postgraduate. He's had 29 mentees. They've had over 40 abstracts, and they are all on his papers. So this is exactly the kind of person that we're thankful to have here at our faculty. He has received for awards the American Thoracic Society Assembly on Critical Care Early Career Achievement Award. And from his very distant past, he was an NCAA All-American in outdoor road and track for 2 years in a row. So I always have to have something interesting to say. But with that, Dr. Churpek, please come up. And welcome to the University of Wisconsin.
Thank you so much for that kind introduction, and thank you all for coming today. I'm very excited to be a part of the new faculty here at the University of Wisconsin. So just before I start my disclosures, I do have a research grant related to a company, EarlySense. I'm not going to be talking about that today. But my research also involves a patent pending algorithm that I will discuss today that was patented through the university, but I don't have any commercial conflicts of interest otherwise. So I'm going to start today off with a case. So this case might be a little different than some of the cases you've seen earlier in Graham Rounds. MC was a 38-year-old male with no significant past medical history or presented to his home computer. He recently made a New Year's resolution to get into better shape. So he types in exercise equipment into a search engine, and immediately, based on his search terms, his demographics, and a real-time prediction algorithm, millions of options come to him in under a second. After browsing several sites, he decides he wants to buy an exercise bike. So he goes to Amazon, and again, based on his past purchases, his demographics, similar purchases by others with similar interests, thousands of options come to him based on a real-time prediction algorithm. So now after doing all that shopping, he's decided he's had enough exercise for one day. It's time to watch a movie. So he goes to Netflix, and again, based on a real-time prediction algorithm, hundreds of different movies come to him based on the previous ratings for him with movies and also other movies that similar people also like. So if you contrast what happens in our everyday private lives with what happens in medicine, I think you're going to see a stark contrast. So a second case is a patient, DB, who came to us at the University of Chicago when I was a resident. This patient was a 67-year-old man with a history of sepsis. He came with a low-grade fever, but otherwise his vital signs were relatively stable. The workup was begun and he was admitted to the general wards. However, at 2 a.m. his vital signs showed higher grade fever, lowering of his blood pressure, and worsening of his respiratory status. The nurse was concerned, and so the intern was called, and the intern in the middle of the night, by hand, is reviewing vital signs, laboratory values, medications, imaging results, clinical notes, trends of all of these things over time while they're juggling all these other responsibilities. I think if we compare what happens in our everyday private lives, where companies are taking all the data they can possibly get, putting them in these incredibly complex and accurate machine learning algorithms to make predictions in order to better essentially make money off of us, compared to in medicine where we are still going through charts by hand and trying to figure out these complex problems all on our own, I think we have to agree that there has to be a better way to do this. There needs to be a better way to take all the data we are painstakingly putting in the electronic health record and using that for real-time clinical decision support to better care for our patients in the hospital. So today, my research focuses on risk stratification of patients, and in particular, figuring out which patients on the general wards are most likely going to potentially have a cardiac arrest or need for ICU transfer or die in the hospital. So I'm going to first discuss why is that an important problem to focus on. I'm then going to talk about what the current state of risk stratification is in hospitals today. I'm then going to talk about how you can actually use EHR data to develop prediction algorithms for patients in the hospital in order to better improve their outcomes. Finally, I'm going to give you a few examples of using real-time clinical decision support based on these algorithms in hospitals and how that potentially can improve patient outcomes. So the learning objectives of my talk today are that first, after hearing this talk, you're going to be able to describe what are the standard methods of risk stratification in hospitals today. After that, you'll also be able to understand how electronic health record data can be used to predict outcomes for patients in the hospital. And then finally, you're going to understand the feasibility and the impact of real-time risk stratification of patients. So why should we be risk stratifying patients in the hospital? And in fact, essentially one way to think about this is how can we predict whether this patient's going to be able to use the phone in the next 24 to 48 hours, or are they actually going to end up in the ICU? So it turns out that most cases of in-hospital cardiac arrest actually occur outside the intensive care unit. So of over 200,000 cases that occur each year in the United States, half occur outside the ICU. And despite decades and decades of research about, what song should we be singing in our head when we're doing chest compressions to get the right rate and, medications and everything else, unfortunately, survival remains very poor. So we really need to start thinking about how can we prevent these arrests from happening in the first place. In addition, there are several lines of evidence that cardiac arrest may be preventable. For example, let's look at the vital sign abnormalities that occur before the event. Now, there's been several studies on this. One from Hillman and colleagues looked at vital signs in the 8 hours before a cardiac arrest on the wards, and they found that about half of arrests have abnormal vital signs prior to the event. When you look from 8 to 48 hours, still about half of these patients are having abnormal vital signs. So in-hospital cardiac arrest is often not a sudden event as opposed to out-of-hospital arrest. Within hospital cardiac arrest, we have hours and often even days to potentially intervene on these patients before the event happens. In addition, if you look at the common causes of cardiac arrest, they are things like sepsis, stroke, myocardial ischemia, conditions where we know that early intervention can improve outcomes. Furthermore, if you look at events that happen, these arrests on the wards, through a detailed chart review, it turns out that medical errors are very, very common. Errors such as delays in diagnosis and errors in diagnosis are happen over half of the time in many of these arrests. In addition, the resident house officer is often the most senior physician at the bedside when these events are occurring. So if we can risk stratify patients in the hospital, we can potentially direct critical care expertise to the patients who need them most. Now, in addition to cardiac arrest, luckily we identify these patients earlier, and many of them actually who are deteriorating get to go to the ICU for potentially life-saving care. But unfortunately, many times these patients are identified too late, and delayed transfer to the ICU has been associated with increased morbidity and mortality through work from our group and many other groups as well. In addition to providing life-saving care, there's evidence that risk stratification can improve the end of care at the end of life as well. For example, this study by Vasquez and colleagues looked at deaths in their hospital from prior to implementation of a rapid response team compared to after implementation of a rapid response team. As shown here, after implementation of the rapid response team designed to intervene and identify patients at high risk of deterioration, more of the patients who died under comfort care with decreased pain scores and decreased subjective suffering. So early identification of critical illness on the wards could potentially also lead to not only saving lives, but also improving the care at the end of life as well. So these ideas and many others have led to the proliferation of rapid response teams, which is a multidisciplinary group of clinicians who come to the bedside to help care for these patients. And this has been prompted by both things like the Joint Commission here in the US, but also across Australia with the Between the Flags initiative, and also standardization of these tools for identification and treatment across the UK with the National Early Warning Score. So with that in mind, how are we currently risk stratifying patients in the hospital? Well, it looks something like this. Maybe our hair isn't quite so perfect at morning rounds, but it's essentially a bunch of clinicians standing around and saying, well, I think this patient might be getting well enough to go home, or I think this patient might be getting too sick and they need to go to the ICU. It's based on our experience and subjective opinion, and as we know, that can vary quite a bit from provider to provider, and it can also change as we get exhausted or overwhelmed with complex patients. In order to improve upon the subjective nature of many of these decisions, many different tools have been developed that are more objective to risk stratify patients. So this is the Muse score. So the Muse score is the most commonly used early warning score in academic centers across the US, partly because it actually is embedded and available in many electronic health records. The problem with the Muse score, though, is, first of all, as we already looked at, and we all know, there are many pieces of information that can be used in these models to predict and help risk stratify patients, but Muse only utilizes vital signs. And in addition, if you look at the different thresholds for the Muse score, these thresholds were completely made by subjective opinion, yet again. In other words, this is not based on patient-level data, but it's all of us sitting around in a room and saying, I think a respiratory rate of 20, maybe that should be a 1. Well, for those of us who've been in a hospital, we know the respiratory rate's always 20, so that might not be very useful. So again, these tools do not have the accuracy that we need because they were not developed using patient-level data. And varying opinion has also led to hundreds of different versions of these scores. In fact, there are many, many different versions of the Muse score, because apparently if you modify the modified early warning score, it's still the modified early warning score. And so when you're a hospital who's trying to figure out what score should we use in our hospital for risk stratification, it's sort of like you send this kid into the 7-Eleven, say, buy me a drink, any drink, right? There are hundreds of options to choose from, and which one do you actually choose? And it turns out which one you choose matters quite a bit. One study looking at the accuracy and sensitivity for death here across a number of different scores, each score outlined here along the x-axis with sensitivity on the y-axis, you can see that the sensitivity for death varied quite a bit across the different scores. So it really matters what tool you use, because some tools are going to cause an enormous amount of false positives and alarm fatigue, and other scores may not detect the events you actually want to detect. So determining which score will work best in your hospital is critical. In addition, if you think about how rapid response teams work, you actually have to identify those at highest risk for deterioration before the rapid response team can get to the bedside of the patients, or before the primary doctor for that patient knows that they're deteriorating if they're not at the bedside. And so if your score is not working well, the whole system breaks down. And in fact, if you look at the different studies that are out there for the effectiveness of rapid response teams, there's quite a bit of variability. And now some of that variability is likely due to how you actually implement things on the implementation side, but I think also some of this has to do with the fact that many, many different scores are being used. So then how can we actually use the electronic health record data that we now have available in data warehouses in many hospitals around the country and take those data to develop more accurate algorithms? So our group, what we wanted to do is to develop an accurate score that's generalizable to many different hospital types for identifying clinical deterioration on the wards. So we essentially modeled then a combined outcome of cardiac arrest, ICU transfer, and death for the reasons I mentioned before, because these are all events we may be interested in predicting. We then used a large multi-center data set, which was funded through our CTSA. And these data then were available from both University of Chicago, which is an urban academic center, but also from 2 suburban teaching hospitals and also 2 community non-teaching hospitals in the North Shore Health System. We were excited to do this across these different hospital types because we believed it would improve generalizability for future studies in other hospitals. For now, what we did was we looked at predictor variables to add to the model that are ones that are universally collected in many hospitalized patients and are collected in a similar way across hospitals. So we looked at things like age, vital signs, and commonly collected labs. Our final study population was over 269,000 patients, almost over 400 cardiac arrests, over 13,000 ICU transfers, and almost 3,000 deaths that occurred on the wards. When you look at the data set with the different hospitals here in the columns, you can see that age, race, as well as the outcome percentage vary quite a bit from hospital to hospital. And we were actually, again, excited to see that because that suggests that we have a very diverse data set, which should improve the generalizability of the model. Now, when we looked at the different vital sign predictors, these are AUCs for predicting in-hospital cardiac arrest. So for AUCs, which we're going to talk about a lot today, the area under the curve 0.5 is a coin flip and 1 is a perfect test. So the closer to the 1, the better the test. And as you can see here, we found that respiratory rate was the best predictor of clinical deterioration, which many other groups have also found in their data as well. We developed the model in 60% of the data and then validated it in the next 40% of the data. So we split the derivation and validation by date to essentially estimate what a prospective validation would look like. And what we found was that our score, which we're calling ECART because Dr. CART is what is called overhead at University of Chicago when a cardiac arrest occurs, the AUC for our score was significantly higher than the MUSE for cardiac arrest, ICU transfer, and death, as well as the combined outcome in the validation cohort. And that was the same actually across every single hospital, where it was more accurate for every outcome in every individual hospital, whether it's the community hospital or the urban academic center. So for us, this solidified the fact that if we just take patient-level data and commonly collected variables and put them in a statistical algorithm, you can actually significantly improve upon the standard of care that many hospitals are using today for clinical deterioration and risk stratification. So one question that came up from this work, though, and maybe it was a question in some of your minds, is, are documented respiratory rates real? Is it always 20 or always 18 here? It just seemed like it was always, one of those numbers, maybe 16. One of the questions we had before moving on to implementation was, how well does the physiology of respiratory rate and real physiologic respiratory rate values compare to what is put in the electronic health record? So what we did was we put a pod device on patients that used an accelerometry technology to determine the real-time respiratory rate, physiologic respiratory rate. And we compared that to what was in the electronic health record. So I'm going to show you two overlapping graphs. I don't think I need to tell you which is which. So the bar graphs are what was in the EHR, and as you can see, it's 16, 18, and 20 is almost always what the value was. However, the physiologic respiratory rate from the accelerometry-based technology was essentially more of a flat and normal distribution, more like what you might expect in the hospital. Now, the second thing we did was we then compared the accuracy for predicting clinical deterioration between the real physiologic data versus the EHR data. So now, who in the audience thinks it's the physiology is the best way to go and it's the most accurate? And then who thinks the EHR data, what's in there, is actually the most accurate? All right, so we have votes for physiology. It turns out that what's in the EHR was significantly more accurate for predicting clinical deterioration. And so we looked at why that is, and it turns out that if you walk in the room, the patient's on the phone, 18. Why do I count? Why do I need to count when they're just sitting there and they're doing fine? Whereas if you get an odd number, 21, your risk goes up dramatically because it means that not only is your respiratory potentially high, but someone cared enough to count for that full minute in order to give you that number. And so what we did based on this was to say, well, you know what, the data in the EHR are actually the most accurate way to do this. So there's no reason to do something fancy and throw a bunch of devices on people. Let's just use the data in the EHR. It's a highly accurate prediction. So in terms of future directions for risk stratification research, there's a few different areas we're very interested in. We're very much interested in using natural language processing of clinical notes to improve upon the detection and potential treatment of these patients. Also clinical orders, diagnostic test results, many other. We essentially wanted to combine all these data together to see if we can improve risk stratification. But another interesting aspect of risk stratification for a patient is, well, you have all the data from the patient, but what about what's going on around the patient's environment? And this thought came from something that I think we see all the time in our everyday life. So what happens when someone crashes in the highway, right? So you imagine, this is an article from a few years ago now where the Google self-driving car actually crashed into a bus. So you can imagine if you're like driving down the highway, you see a car crash into a bus, and then all of a sudden the car was like driving normally for like a long time and making turns and all that, and then you look over and there's no one in the car. So you might stare a little bit and turn over, and essentially that's what happens, right? When on the highway, when these events happen, we're all sort of slowing down and turning over, and in the hospital, the same thing happens. When arrest happens or someone who gets really sick, all of a sudden you get all these physicians and nurses and many people who aren't even involved in that patient's care who come by just to see what's going on. Then think about everything that has to happen between getting the patient then to the ICU and all the handoffs and transfer orders and notes and documentation, talking to the family, talking to the other team. It's an incredibly resource-intensive event. So we hypothesize then is when an event like an ICU transfer or cardiac arrest happens in the hospital, that it affects the other patients in the same ward and potentially increases their risk as well. And so what we did was we essentially took each individual ward and we used our ECART score to essentially say how sick each patient was, to essentially adjust for the severity of illness. We adjusted for many other things in this model. And what we asked was when one of the patient has an event, what is the independent contribution of that event on the other patients on the same ward's risk of the event in the next 6 hours? And what we found was that the odds of critical illness increased by 18% when one of these events happened. And in fact, when 2 events or more happened on that same ward, the odds of critical illness increased by over 50%. So this suggests that when you're thinking about risk stratification of patients in the hospital, we should be thinking not only about what are their vital signs, what's going on with them, but also what's going on in their environment as well. We did another study looking at where on the ward, what does that matter in terms of their risk of an event, and we found that patients in the corner rooms farthest away from the ward entrance had increased mortality. So it really does matter, those patients in the corner room where no one ever kind of sees or goes into, right? It really matters the environment in addition to what's going on with the individual patient. This also, I think, provides information about how you might want to utilize your rapid response team. When your rapid response team comes into the room of one patient on that ward who's very sick, you may consider having them ask the charge nurse for that unit or ask other people or just sort of take a walk around and see who else might be having some issues because of all the resources in that one room. So in addition to thinking about the patient's risk themselves and their environment and other variables we can put in the model, another area that our group is very interested in is this area of machine learning. So when you think about improving model accuracy, companies like Amazon and Netflix and even the United States Postal Service is using machine learning in our daily lives. Now in Chicago, the mail still never came to us, but here it actually seems to be a bit better. But also, as these companies are creating self-driving cars or, the computer algorithms that can beat us in chess and Go, they're using machine learning to actually improve the prediction accuracy of their algorithms in order to essentially make more money off of us and improve our customer experience as well. Machine learning really is just the computer science field of learning from data. It includes things like linear and logistic regression. So if you've used linear and logistic regression before, you can say you've done machine learning. But it also includes things like decision trees, neural networks, support vector machines, and many other algorithms. So what we wanted to do then was look at the same data set, that multi-center data set that we talked about before, with, again, that separate derivation and validation cohort. And instead of using logistic regression as the model algorithm, which is what we used for our original eCart, we wanted to see how the accuracy would change if we switch it from logistic regression to a neural network, to random forest, to all these other algorithms that are out there. And lo and behold, what did we find? It turns out that the random forest algorithm and other similar algorithms, more modern machine learning algorithms, were significantly more accurate than the machine learning algorithm that we use in everyday practice in clinical medicine. We're deriving things, logistic regression. So all you need to do if you want to improve accuracy, you don't necessarily need to add in all these extra variables and figure out how to get them in your model in real time. If you just switch from a very old machine learning algorithm, logistic regression, that we use in medicine for developing things like the Apache score, the SOFA score, and many other things, we can switch to more modern methods, and the improvement in detection and alarm fatigue that you would see from going from Muse to just a logistic regression algorithm, you essentially can have that same level of improvement by switching to a more advanced algorithm like random forests. So what are random forests, right? So what are some of these algorithms that are out there? Because there's more and more publications using these types of methods. Well, random forest is essentially based on a simple decision tree. You can imagine if you applied a simple decision tree to essentially separate those who had the event versus those who didn't on our data, what would you see? Well, first, probably you would start with respiratory rate, right? If respiratory rate's greater than 20, that's not good, right? So we'd separate that. And then maybe it might go to age next. And essentially we'll figure out, based on the data, which cutoff best separates those who have the event versus those who don't. And as you can see, you essentially go down this tree, and at the very bottom, it then makes a prediction on the probability of what the event would be. So that's a decision tree. And essentially, a random forest, then, is a combination of hundreds, if not thousands, of these different models. Now, one of the challenges of these algorithms is that they're often thought of as black box algorithms, where you don't know what's going on in the model, so as clinicians, maybe we shouldn't trust them. But it turns out that over the decades and the people have been working on these different algorithms, they've actually developed many ways to essentially look under the hood of these models and determine what are the most important variables for these models, and does it map to what we would consider to be clinically relevant and clinically important. And in fact, if you look at the variable importance of the random forest model in our data, you can see that, again, respiratory rate is the most important predictor variable in the model, followed by heart rate, age, and again, some of the laboratory values being less important, but still in the top few. This is, again, exactly what we would expect based on prior literature and also based on our other models that we've seen. In addition, you can also look at how risk varies across a predictor. So here along the y-axis is risk, x-axis is respiratory rate. So if you get that 16, 18, or 20, your risk is very low for the event. But just as you might expect, if you're not breathing, your rate is very high. But also, as soon as you go above 20, your risk goes very, very high as well. So again, it's exactly what you'd expect if you were to ask a clinician what the relationship would be. You can also do this with age as well, which we did. And it turns out that, unfortunately, no matter how you model it, turning 40 really is bad news. But so essentially what we've been doing on the clinical implementation side is saying, okay, we're going to show you, the clinicians and the implementation leaders, what's going on with this model, why it's making these predictions, which improves the face validity of the model and their confidence in the prediction that it provides. Now, the next question we had was, can we go deeper, right? So the area of machine learning that is so hot right now is this area of deep learning. So if you think about it, if you pull up your phone and you have a picture of you in one picture, and then you can actually then find every picture in your photo album that has you in it or your friend in it. When you're talking to Alexa, you're talking to Siri, or when you're thinking about self-driving cars, the algorithm behind many of these things in our private lives now is this area of deep learning. And what deep learning is, it's really just a succession of a combination of neural layers and layers of neural networks combined. And essentially what they're doing is, for example, in the case of image recognition, so you might imagine image recognition of, pathology slide, cancer versus not, or self-driving car, pedestrian versus sign, cat versus dog is sort of the classic one. Here, with a car, it takes all the pixels from the image. It then successively, with each layer of the neural network, it starts learning lines and edges, and then it starts combining those into shapes like wheels or eyes. It then combines those into more complex shapes, and at the very end, it can then make a prediction: cancer, Audi A7, whatever you're interested in. The problem with patient data, though, is, as we know, the vast majority of patient-level data is not image data, right? It's vital signs, it's labs. So what we wanted to do is think, how can we trick these deep learning models that focus on pictures that have been so revolutionary in our private sector into thinking that EHR data, like vital signs and labs, are pictures? And so what we did was we took the different vital signs and labs and diagnoses and nursing documentation, interventions, medications, and all those data, put them here along the y-axis, and then along the x-axis is time. And then you then normalize all those data, and you essentially then get a picture, a snapshot of what a patient's, in this case, their first 48 hours of their hospital stay look like. We then put those into convolutional neural networks, which are essentially the algorithms that people use with deep learning for pictures to see how accurate these models actually could be. So what we did was we took 70% of the data for derivation, which goes along the top. We tried a number of different algorithms. I don't have the time to go into the details right now, but essentially we use algorithms that are focused on pictures. We also then added algorithms that are able to understand the time ordering of the data as well, and combine those together into one deep learning algorithm. And then we also then compared it in a separate validation cohort to things like the Muse and the SOFA score and other things, other models that essentially we often think of as sort of classic models in critical care and patient medicine. What we did was we were trying to predict, in this case, use the first 48 hours of data to predict in-hospital mortality. It turns out the deaths happen typically 7 days or so out, so we're really trying to predict a death that happens at least 3, 4, 5, 6, and sometimes several weeks after the data that we have. And what we found was that these deep learning models were highly accurate. You can see SOFA scores AUC was almost close to just a coin flip. Muse is in the middle, and then the deep learning algorithm we developed was highly accurate. So again, this suggests that if you start using these more modern algorithms, you can dramatically improve prediction accuracy over what we use in clinical medicine. And another important aspect is, even though this model can have thousands and sometimes even millions of parameters, and you're not going to be able to get an equation from this model, but what you can do is you can use many different techniques to actually highlight the attention of what parts of the picture are most important for making the prediction. So here that's highlighted in red, and you can see that a number of the diagnostic tests, such as CAT scans and X-rays, the interventions, so those are some of the fluid boluses the patient received, and also some of the vital signs as well, although not as much. Those are the things that are most important for making the prediction of the model. So you can still look under the hood of these even very, very complex algorithms as well. So an important question then is, now that we can predict who's deteriorating to a very, very high level of accuracy, imagine being the rapid response team coming in, right, or the clinician saying, a computer told me to come in because you're sick. So we really want to understand why, right? You really want to think about what is the why here. Why are they actually deteriorating? So what we did then was we did 1,000 chart reviews of patients who were deteriorating to figure out what was the ultimate cause of their deterioration at the moment they became high risk. Now, I'm showing you a small sample of that, but what we found was that sepsis was the most common cause of clinical deterioration in the hospital, which for many of the clinicians in here, I think that's probably not too surprising. Other things like arrhythmia and hypoxemia, ARDS, were also important as well. So, as many of you know, when we think about sepsis, the question always becomes, well, what is sepsis, right? So sepsis historically had been defined by the SIRS criteria, right? So temperature, white blood cell count, heart rate, respiratory rate. If you have abnormalities in two or more of those, and we suspect infection, then you're septic. Now, in 2016, sepsis was redefined by the international group, and what it's now defined as is life-threatening organ dysfunction caused by a dysregulated host response to infection. That's their new definition. So if you think about it then, what is sepsis? Sepsis is really just the combination of being critically ill and being infected. That's what sepsis is. So from the prediction modeling standpoint of view, these are actually two different prediction problems, right? When you're predicting critical illness and deterioration, you're thinking about things like respiratory rate, right? When you're thinking about infection, respiratory rate's important, but other things like temperature and white blood cell count and immunosuppression and all of the history of all those things, right? Those things are probably more important than that type of a model. And so we're actually, what our lab has done is really approach this as two separate problems. So when you think about risk stratifying infected patients, I think some of you have probably heard of the QSOFA score. So along with redefining sepsis, they also came about with the QSOFA score, which essentially is hypotension, altered mental status, and high respiratory rate. They developed this in a hospital data set of like 500,000 patients. And when you look at the data, it turns out that SIRS versus QSOFA is really just the trade-off between high sensitivity for SIRS, high specificity for QSOFA, but both of them really only have sort of or fairity, sometimes even poor accuracy for actual risk stratification if you're including them in your algorithms. So what about general early warning scores? So things like MUSE, right? Not developed for sepsis, but maybe it could accurately predict outcomes in sepsis. What about ECART? Again, developed for any patient in the hospital, but how does it do for patients with sepsis or suspected infection? And in fact, what we found was, again, with AUC, you can see here along the y-axis, ECART was the most accurate score for risk prediction of patients where the physician suspected infection, as heralded by either antibiotics and or culture orders. MUSE is second, and then this score was developed, QSOFA, specifically for infected patients, actually was much less accurate than these other models. So again, if you're going to risk stratify patients with infection, it turns out it's often similar vital signs in labs than those patients who actually don't have infection. And you potentially can use the same model for risk stratification of everyone, as well as for those with suspected infection. Now, an important question is, of course, then, who is actually infected, right? In real time, it can be incredibly hard to determine when the patient first walks through the door who is actually infected. One group over a decade ago now in a single center study did some chart reviews to figure out who is infected and developed the infection probability score showed here. It actually looks similar to some of the other scores, but includes things like CRP that we don't often get in many patients, and actually includes the SOFA score, which is a severity of illness score inside of it, so it's actually quite complex. It was only developed in ICU patient population, and as many of us know, right, so probably 70% of the patients with infection are community-acquired infections, so it's only going to work on a very small subset. So what we've done then is we've now done 4,000 manual chart reviews across 6 hospitals as part of our R01 grant. We then have EHR data from over 2 million admissions across 7 hospitals. We did a pilot study in a small sample of these charts just to see can we predict who's infected using only a couple hours of data when they first come through the emergency room. And what we found was a random forest model designed to predict infection using only a few hours of data was significantly more accurate than the SIRS criteria or MUSE, or the IPS score as well. And again, because this is actually done in many of the cases is well before, sometimes hours to even days before the antibiotics were given, it suggests this model may have some utility. And so now in the future studies, we're going to combine and develop a model using the whole 4,000 chart review set. In addition, one of the areas we're moving into now is to really try to build algorithms for all the different causes of deterioration. So this fall, we'll have our sepsis model. We also have an AKI model that's a gradient boosted machine algorithm that predicts severity, a likelihood of AKI in the next 24 hours. We're then using that in a randomized controlled trial to prompt early nephrology consultation. We're also 1,000 charts into looking at all the different causes of deterioration with a planned 4,000 to 5,000 full chart reviews to develop models for all these different conditions. So finally, I want to end my talk today by talking about real-time risk stratification in action and can this actually be done and how can it impact outcomes. So the first thing we did was to do a silent pilot study where we essentially ran our score in the background. Because of course, our model AUC might be 0.8, but if the clinician's AUC is 0.9 and they're already doing all the right things, there wouldn't be a reason to implement the model. So it's really important to make sure that your model will add value to what the clinicians are already doing. So again, our prior data was based, with prior algorithms were using retrospective data. So we wanted to test the feasibility of running it in real time and compare it to current practice. So what we did was in over a year period, we looked at 1 medicine and 2 hem-onc wards. We then compared accuracy of our ECART score to what was going on with the rapid response team. We had a priori categorized the score based on what probability or what output thresholds we would want for an automatic rapid response team call, as well as for proactive rounding. And based on those thresholds, then again, we calculated the score using the EHR data, but no clinician could see the score. The outcomes identified for the rapid response team, unfortunately, was only about 10% of the arrests and only about a third of the ICU transfers were seen by our rapid response team prior to the event. However, looking at the high-risk ECART score, which are prompted an automatic page, you can see that it identified over essentially 80% of the cardiac arrests and half of the ICU transfers, a significant improvement in accuracy. If you add on our intermediate threshold, they would have seen all of the cardiac arrests and 2/3 of the ICU transfers, again, based on those a priori cutoffs we had developed. Now, an important aspect of this is also timing. So if you look at the hours before event here along the x-axis and the percent of events detected along the y-axis, unfortunately, our rapid response team was getting called only about an hour before the event was happening. So essentially, they were basically being glorified transporters. They'd walk in the room, they'd throw on oxygen, the patient was already crashing, and they needed to go to the ICU or have chest compressions. You know, they're not going to be able to prevent these events if they get there only at the time of the events actually happening. If you look at our ECART score, what we found was not only was it detecting many more patients, it was detecting these events over 30 hours before they happened. So if you think about what happens when you walk in the room, someone's starting to deteriorate, you have to order a bunch of labs, maybe a CAT scan, maybe get some consultation, maybe start a new antibiotic or some other new therapy and sort of let all of that start working. We were very happy to see the fact that we had 24 hours or more lead time for these patients. So what we've done for live implementation, we have an automatic rapid response team call for the highest risk patients, essentially automatic paging through the system, so nothing manual there. For intermediate risk patients, the rapid response team is proactively going from room to room in between the high-risk patients. And finally, for the low-risk patients, we're continuing present care, but we're actually also starting to allow those patients to sleep overnight. Because we just finished a randomized controlled trial that showed that it is actually safe to allow these patients to sleep overnight if they're very low risk. And the patients are very happy about that, surprise, right? We now have developed an interface where you can sort your list individually or the entire hospital from sickest to least sick based on our score. You can look at your individual patient and watch how their values change over time. We also highlight what are the vital signs or labs that are driving that risk score so the clinicians know why they're being called to the room. I'm being called to the room because you have a high fever, you have a high heart rate, you know what, and putting all this stuff together with your high white blood cell count, I think you're septic, right? So you can actually think about this and look at that before you even walk into the room. Importantly, we've also paired the model with clinical pathways that were developed by the clinical and physician and nursing leaders in the hospital to figure out what should we actually be doing. So these include an initial reassessment, including redocumenting vital signs, a sepsis screen, because again, sepsis was the most common cause of deterioration in our data, A worry screen. So how concerned is the nurse about this patient? Because in other work, we've shown that is a very strong predictor of deterioration as well. And then finally, clinical actions that we recommend, including reassessment, activating the rapid response team, continuing present management, calling the primary doctor. And we've also given our rapid response team the ability to automatically order lactates as well. So an important aspect of all this is, of course, you can build a model, but will they come and actually use it, right? And what we found at this hospital, we've now implemented eCard across 25 hospitals and many more by the end of the year, and utilization is very high. The clinicians are seeing and using this. They're using the pathways because it's so much easier to just go to the high-risk pathway and one-click order the things you want as opposed to having to find all these data and all the orders all over the EHR. Implementation has significantly decreased cardiac arrests at the University of Chicago by over 50%. Our cardiac arrest rates on the wards are now the lowest that they've ever been. In addition, other hospitals have independently analyzed their own data after implementation. So, for example, the Alexian Brothers group was kind enough to allow us to share their slides for this talk. They did a baseline and then pilot study using our score. You can see that although case mix went up slightly, their cardiac arrest rates also went down by over 50%. In addition, although length of stay overall didn't change, the length of stay in the ICU significantly went down, resulting in significant cost savings. And a lot of it had to do with the fact that the patients were now going to the ICU earlier. You know, they weren't going there with 3-4 organ failures and an intubation. They were going there with sort of 1 to 2, and then they're getting early treatment, rapid resuscitation, and then they're getting out of the ICU much sooner. Finally, the North Shore group just presented their own data at ATS this year showing significantly improved mortality after implementation with a number needed to treat of 20 patients to prevent 1 death in the hospital. So I just want to end my time today by talking about a case. This case is no longer me or someone else at the computer. So this is a 35-year-old female who presented to the emergency room with new shortness of breath. Her symptom onset was sudden, associated with sharp chest pain. Otherwise, she was healthy without any medical problems. So this is her x-ray, and I can't see if there's pulmonary fellows in the audience. I'm not going to pick on anyone, but you can see there is a pneumothorax here on the patient's x-ray. So a chest tube was placed with immediate relief of shortness of breath. The primary team a few days later then clamped the chest tube. These are the vital signs that were documented in the electronic health record. And there's a little debate about whether anyone was called or someone was called but they didn't answer. But essentially, this was documented, but nothing happened. Respiratory rate of 32. Yeah, that's not good, right? She's not doing good. So 15 minutes later, and I think we could all imagine we could be doing chest compressions on her in 15 minutes, right? Or certainly getting her to the ICU. However, it turns out that on that same day, eCart was turned on for the first time at the University of Chicago, and they received their very first page for a high-risk patient, and it was this 35-year-old female with no medical history otherwise with recurrent shortness of breath. They're critical care trained nurses. They walked in the room. They knew exactly what they do. They put the chest tube to wall suction. The patient all of a sudden felt incredibly better. Vital signs normalized. The patient then went home a few days later. You know, and to me, you know, I love developing the models and, you know, thinking about machine learning and all these fancy techniques that we could use. But this really hit home the fact that we really have such a great potential to improve the outcomes of our patients if we're really using the data that we have in our EHR and actually use those data at the bedside to improve patient care. So I really think the future of risk stratification in the hospital is not the exhausted intern in the middle of the night, but it's actually the intern in concert with, in partnership with these algorithms to make sure that nothing slips through the cracks. And these algorithms can be used for the rapid response team activation. They can be used for the primary physician or the primary nurse to see how their patients are doing or their patient lists, and even help determine, you know, should this next patient who comes, this new admission, what nurse should they even go to, potentially as well. And then finally, we essentially go over every single arrest or adverse event that happens in the hospital using our eCard score to determine were these predictable events, to think about how can we prevent these events from happening in the first place. So I acknowledge the many, many people who've helped me along the way, especially Donna Edelson, who has been my primary mentor and collaborator over the years and all of this, and the implementation scientist who's gotten many of these interventions up and running, and all the faculty and students and other collaborators. You know, this work could not be possible without them, and I really want to thank them. And of course, I want to thank my wife in the audience as well for supporting me and allowing us to get out here. And I'm so happy to be here at the University of Wisconsin as part of this department. Thank you.
Okay, so my brain is like blowing up and super tired. It's like intense. That was super intense and awesome. Can I take questions from the audience? Steve.
Dr. Churpek, very exciting and thought-provoking information. What I'm wondering is, I didn't hear as much as I heard about the predictive strategies and models that you were developing. But I'm wondering, to what extent is an operative characteristic play into this too? Like, so does a house staff member versus a faculty member versus a hospitalist or consultant, you know, how does the information that's coming to us then get processed to be able to react? And I'm also curious, not just as the operative characteristics across the medicine continuum, but when you interject nursing or other respiratory therapy input into this process, how might it influence the outcome?
Right, so that's a great question. Essentially asking how do we operationalize a score in practice when there are many different players in this, with whether it be the bedside nurse, the physicians, the residents, who should be getting the call, and how do we actually get this to be most effective? So what I would say is the short answer is we don't know right now whether it's better to have the rapid response team get the first page or the nurse get the first page at the bedside or the clinicians. One of the reasons we're really excited about having the score now running across 20, 25, 30 hospitals now is that we can actually start studying that. But our belief is that until we have more information, the most important thing is to get this score in the workflow of the clinicians, exactly at the right time for the right patients when they need it. And so for some hospitals, that means that if they have a dedicated rapid response team, that could mean that use the score to help figure out where the rapid response team could be. If they don't have a rapid response team, then the question becomes, based on your workload and the workflows of your clinicians, who is it best to give the information to? And so we spend a lot of time at each individual hospital talking with them about their workflows and what they think will work best for them. And we have now solutions in terms of not only do we have a solution in the EHR, we have an iPad app, we have actually a sort of a EICU interface as well. So there are many different ways that this can be used. And we think the most important way is to try to work within the culture of that particular university or hospital in order to make it easy and something that everyone wants to use, because we really want everyone to be using it.
Dr. Vogelman?
That was just a wonderful talk. I was just looking at some of the curves. It seems like your AUCs were better with really great dichotomous variables. I arrested or I didn't, or I died or I didn't, as opposed to I got into an ICU and some doctors make a decision. And the curve began to get hyperbolic. You got really good in the last hours in there. Do we have the wrong parameters 48 hours earlier? Are there certain diagnoses that you're discovering that typically get worse before they get better when someone comes on a ward in a hospital?
Right, so that's a great question. Is how can we? Is there other information we can incorporate in order to better improve the model's accuracy overall, but also getting to some of the patients earlier who may have different trajectories over time? So that's why one of the things that we're really interested in is using things like natural language processing of notes to pull out potentially important information about the past history and the current condition causing them to be in the hospital. We're also incorporating a number of different orders, like are they on antibiotics? Did they get fluids? Are they on a diuretic? And those pieces of information as well. And our thought is by essentially making these models more personalized, we're going to not only improve the accuracy overall, but also improve the personalization of accuracy, trying to get this earlier for all the patients that we can.
Beautiful, beautiful work.
Oh, thank you.
I'm thinking about the physician gestalt, about how a patient is doing. And it's probably a combination of a bunch of variables, maybe a little hard to pin down. Pasty complexion, how fast they respond to questions, and what observations they make, maybe what the family says. And I wonder if that information, if you could grab it in some way and feed it in along with all the other variables, would increase the predictive value of your parameter P-card.
Yep, so that.
Thought about doing that, or how to do it?
Yeah, so that's a great question. How can we combine clinical intuition and gestalt with the algorithm? So we've done a few things in this area. One thing we've done is to compare accuracy for predicting deterioration between clinicians and nurses compared to the Muse. it turns out that they're similar, right? So the accuracy is similar between Muse and the clinician's intuition. So it's not as accurate, their intuition is not as accurate as our score, and using a number of different variables, but it does add a significant amount of value. And so one of the reasons why we're building the nurse's worry into the pathway is because in the future, once we have enough data, we're actually going to then add that into the algorithm itself. So then you can combine the clinician's worry with the machine learning algorithm as well. Because our belief is that the combination of both of those together is going to be much more accurate than either one of them alone. Because again, we want these to work in concert. We want the machine saying, this is the answer, so do this. We want it to be a combination and partnership between the algorithm and the clinician at the bedside. Yeah, so should we be including information regarding geographic information or maybe even characteristics about the patients of the hospitals? How would that impact the score? Well, what we found was that we've now validated every time we go into a new hospital, at least for the first few hospitals, we were validating our score at every hospital. And it turned out that the accuracy improvement over Muse was exactly the same. It was always like, a significant improvement in similar AUCs at every hospital we looked at. We actually just published a study looking at LTAC patients, and again, showing the exact same accuracy improvement compared to Muse and what we found in the inpatient setting. And so what we would like to do in the future is, as we get more hospitals involved with the score, is to also start pulling out information from the individual hospitals, like nurse staffing ratios, case mix, right? Other, night staffing, other information about those hospitals that may impact the risk. So not necessarily geographic in the sense of where they are in the U.S., although we have hospitals in California and other places, we absolutely could do that, and I think we should. But also thinking about what characteristics could we add to the model so that we have a new hospital in Texas. We don't have a Texas coefficient, but we certainly could have a nurse staffing ratio, nighttime coverage, who's running the rapid response team, and all of that in the model as well in order to improve the model's accuracy and performance. No, thank you.
I'm curious about what your procedure was for determining the relevant clinical cut points for making your mild, moderate, severe categories, or for somebody using this model to take action or not, that balances the sensitivity and specificity in a way where you're still hitting all the patients who will have this event as possible without overwhelming the response team with false positives.
Yeah, so that's an excellent question. How, you develop a model, so the models we're developing output a predicted probability. And that is essentially an infinite number of choices then for your threshold. So how do you choose your threshold? So what we've done is we match the threshold to the resources available at that institution. So if you have a rapid response team that could see 10 patients on average per day, we will put the threshold right where you need it, where you can see those 10 patients per day. Right? Because again, we don't want to flood you with new alarms that you're not going to be able to act on, right? And so at each hospital, we really focus on matching the model's thresholds to what the resources are in that hospital. And that's also why we have a high-risk threshold, which our recommendation is always immediate action, versus intermediate risk threshold. And again, those can be moved based on, you run it in your hospital, you're finding that your rapid response team's sitting there on the computer and not seeing any patients because there's no one's flagging. You can move that at any point. And so we have it dynamically changing based on the resources of the hospital.
Thank you very much.
All right. Thank you, everyone.